So the topic now is the impact of antiretroviral drugs on cardiovascular health. These are my disclosures, and this is the outline of the presentation. I will try to be as practical as possible. And the first point is the impact of AIDS treatment on cardiovascular health. And I'm afraid that in the old days, early cardiac manifestations of HIV included endocarditis, myocarditis, cardiac tamponade, malignancies, and a number of rare diseases that, but this time is over. I think that we seldom see one of these cardiovascular manifestations in these patients nowadays. And the problem is the late cardiovascular manifestations because of many reasons. Because the patients live longer, but mainly because the increase of risk factors. And you have seen this data in several ways, but it points out that in patients in HIV positive individuals, there is an increase for angina pectoris, myocardial infarction, peripheral vascular disease, and other cardiovascular diseases. And this is an important increase. It's at least twice as much. And it doesn't depend on the age of the patient. For every single age, there is an increased risk for cardiovascular diseases as compared with the population without the infection, And some of the risk factors not only are present and are more frequent, but also are more dangerous. And this slide is absolutely impressive. If you have a look at the slide, you see that in non-infected people, smoking is not good. That is not news. But in HIV people, the difference between smoking and non-smoking has a tremendous impact on mortality. So we have more risk factors, but also we have more potent risk factors. So the effect, a particular risk factor for cardiovascular disease, is much, much more dangerous in patients with HIV. And to begin with, I think that one independent factor for cardiovascular diseases is HIV positive itself. So somehow it is the same with cancer. It is not only the risk factors, the disease itself, because of different mechanisms, because of the treatment or because of other reasons, is an independent risk factor for cardiovascular diseases. So that is something to consider, because we see why later. So the next question is why there is this increase in cardiovascular diseases, or the risk of cardiovascular diseases in these patients. And there is a number of reasons, and some are obvious. Aging is, the life expectancy of these people is much longer than 20 years ago. So it's not exactly the life expectancy of a healthy person, so to speak, but it's much longer. So if you are getting older, you get more probability of having a myocardial infarction or any cardiovascular disease. And if you live forever, you will have dementia or one of these things. So aging plays a very important role on the increment of cardiovascular diseases because of the longer expectancy. But there is other reasons for the increase in cardiovascular diseases. I already mentioned the independent relationship of HIV with cardiovascular diseases, and it may be linked with the inflammation that takes place in the disease, of metabolic alteration, endothelial damage, such including endothelial dysfunction and other mechanisms. The use of antiretroviral therapy may have a toxic effect, direct toxic effect on the myocardium or in the vessels, again with endothelial dysfunction. And maybe the new compounds, TAF and so, may be less toxic than the others, but it is not an excuse to say that we have to change the treatment. I think the treatment for the disease has to be taken in considering the efficacy of the treatment, and the secondary effects are so vast that cardiovascular diseases is only one. But it's more important the permissive lifestyle of these people that is already supporting the burden of a stigma with HIV, that somehow the patients as well as the physicians, we are neglecting the prevention of cardiovascular diseases. And that is a very important point from the practical point of view. There is a direct relationship, and probably TAF are less toxic than the previous compounds we were using, but that is not the point of my talk. I think that the issue here is that the tremendous increase in cardiovascular risk factors in this population through the years has been the result of somehow neglecting the identification of the risk factors and treating the risk factors, you know. Hypertension can be treated, can be controlled. It is very rare that you cannot control hypertension if you focus really on the problem. The same with dyslipidemia, the same with diabetes, not to mention smoking or sedentarism or the way you eat or the way you exercise. So cardiovascular risk factors have increased tremendous, and that is probably the single most important factor for the increase in cardiovascular diseases in this population nowadays. So the next question is, how can we measure the risk? And there are different ways, and let me tell you two concepts that are very important. The addition of different risk factors for cardiovascular diseases multiplies the risk of the cardiovascular disease. So it is not adding, it is multiplying. And if you start with something like the disease itself as the starting point, this is having a tremendous effect on increasing the cardiovascular risk of this population. So in this graph that comes from the Framingham study, that is the mother of the epidemiologic studies in cardiovascular diseases, you can see that if you only have a single risk factor, that is a high cholesterol, the difference between in the risk of for cardiovascular, the probability of cardiovascular disease from a low cholesterol to a high cholesterol increases several times. But if you are adding some extra risk factors such as hypertension or diabetes or smoking, the risk is rampant. So adding risk factors, common risk factors, increases the risk in an exponential way. The second important point is that if you already have the disease, if you already have a diagnosis of peripheral vascular disease or myocardial infarction or angina or stroke or whatever, the risk increases with every addition or with an addition of a single risk factor is multiplied several times. So the more potent risk factor to have another episode of cardiovascular diseases is already having an episode of myocardial infarction or stroke or whatever. So the addition of risk factors makes a big difference on the impact on the cardiovascular outcomes. So we can use risk scores, but you see that maybe we have too many risk scores. And when we have too many of the same thing, it means that the perfection is not found yet. We can use the Framingham, but that is good if you are in the United States, and in any case it doesn't apply to people with AIDS because that is not included in the score. We can use the European Society of Cardiology risk score if you are living in Europe, so the score is different, or the risk is different if you live in Northern Europe or Southern European countries, but again it doesn't consider the majority of the risk factors that we are discussing today. We can use dedicated or specific scores, such as the DAD or EuroSIDA or others, but again, these are somehow complicated. You have to use a calculator, you have to use your phone, or you have to do some numbers, some typing. So maybe it is, from the practical point of view, it is more simple and more practical to use the KISS rule, or use your fingers to count the risk factors. You know that if there is a single one, well, that is not so important. You have two, if you have two, and that is very easy to have 2 or 3 risk factors at the same time, then you're getting in trouble. But in a way, as risk factors for cardiovascular diseases, are so easy to identify and are so well known to the population that are here and outside this room. So because it is sedentarism, it is smoking, it is hypertension, it is diabetes, it is hypercholesterolemia, who is not aware that these are the risk factors, the main risk factors for cardiovascular diseases. So you can use your risk score with your hand and take one risk factor, AIDS, another risk factor, AIDS, another risk factor, hypertension or diabetes or whatever. And if you have one or more of two risk factors, you may be in trouble. But in any case, what is the reason of not treating the risk factors you find? What is the reason of not recommending to stop smoking? What is the reason to not do something to control the hypertension? So I think that the risk factors are very important, are very easy to identify. You can use calculators, but to me, the value of the risk scores is to increase the awareness, because you can explain to your patient that, you have this risk score, you add some of these risk factors, whatever, and the value of the risk you have, the probability you have to have a myocardial infarction or whatever, is twice as much or 10 times as much as a person that does not have uncontrolled hypertension or is not smoking or whatever. So the risk scores are very useful, but may not be practical. And in fact, in the cardiovascular field, we cardiologists do not use really the risk scores in the sense of measuring something and jotting down this value in the file of a particular patient. So how can we prevent or treat this increased risk or the cardiovascular diseases in this population? There are good guidelines. Again, there is this guideline that is dedicated to patients with AIDS. And of course, you are aware of that. The last edition is from this year. And there is a recommendation of, controlling blood pressure or whatever every year. Or why should I calculate the risk every 2 years and not every year or not every 5 years, And I think that, that is a good guidance. But what is the reason not to take the blood pressure of a patient that goes to a specific consult when the blood pressure is routinely taken by the GPs when they go because they have flu and don't have the risk of cardiovascular diseases as high in this situation? So I think that it is not a matter of every year or whatever. I think that it is the opportunity. Every time you have the opportunity to contact the patient, you have to explore somehow if the patient is smoking, if the patient is exercising, if the diet is fine or not, and you may take occasionally blood pressure or diabetes or whatever. Because if you take this at the beginning, it may change. So the risk is dynamic. And unfortunately, the risk is increasing all the time. And you have seen that a clear example that the classic cardiovascular risk factors have a tremendous increase in the evolution of patients with HIV infection. Then there is the treatment. Again, there are guidelines, again with different guidelines, but more or less are saying the same. And what we use for cardiotoxicity in cancer patients, we don't have that in AIDS, for a reason that we'll comment in a few seconds, is that it's a checklist. And so when the patient comes to the cancer specialist, there is a checklist that is very simple. It's if the patient smokes or not, if the cholesterol is above the normal values, what is the blood pressure and what is diabetes, and if there is anything that is found here, then you have to start the treatment for the appropriate condition. Or if you don't want to do that, or you don't feel that you are qualified to do that in a proper way, send the patient to someone that can take care of hypertension or counseling for stopping smoking or whatever. And if you suspect that the patient has already a cardiovascular disease, send the patient to the specialist as well. So that is a very simple rule to take care of the control of the risk factors. And it is so simple that it is so difficult because it is just common sense. And common sense is so difficult to apply. Everybody knows the risk factors, and not everybody is paying the right attention in real life. Something that is important, and for that you need a table or a computer, is that when you want to start a treatment for correcting the risk factors, the cardiovascular risk factors, there may be some interactions between the treatment that the patient is receiving and the drugs that you are going to prescribe for the control of hypertension or whatever cardiovascular risk factor. And that is very difficult to remember all these interactions of increasing the plasma levels or decreasing the plasma levels of a particular antiretroviral drug or whatever. But if you have a look at, you have to have this table at hand to treat this, to use cardiovascular medications. But the bottom line here is that the wrong part of the table is the use of calcium channel blockers. And we cardiologists can live without using calcium channel blockers. Because we use these compounds for the treatment of hypertension or the treatment of arrhythmias, but we can do the same job using other compounds such as beta blockers or ACE inhibitors, or which are much safer. And the same with the statins. Maybe simvastatin is the less preferred choice, but with beta blockers, atenolol is the best choice. But this table is extremely useful, and you have to have it at hand. So in conclusion, I think that it is quite clear that cardiovascular risk is increased. That is no doubt in that. In patients with HIV, with or without ARS, probably tough and new compounds are safer and less toxic than the older ones. But in any case, the indication of the treatment for the disease is to be made by the specialist that knows what is going on with the combination of these things, because I guess that you never use a single compound to control this disease. And it is extremely important to be aware of the increase in cardiovascular risk factors and making attention to the counseling of the patient for a health lifestyle, and identifying the common risk factors and controlling the common risk factors is the best way to decrease this epidemic of cardiovascular diseases that is becoming more and more apparent nowadays. Thank you for your attention.